I'm going to take off the dog slide, so hopefully you've already decided what dog you are representing this morning, and I'm going to hand over to Astrid. Thank you, Astrid.
Sure thing. Okay, I'm just going to arrange myself here.
Well, you are now the host.
Okie dokie then. Can you see my screen?
Yes, we can. Thank you very much.
Great. Okay. Cool. Hi, everyone. Thank you so much for having me in this session. Today, I want to give you a quick tour around your immune system and then get into some specifics surrounding the COVID vaccine. So, excuse me. Who am I? Also known as why should we listen to her? And to that, I say, firstly, it's really great that you're skeptical, and you should keep that skepticism. Skepticism is really healthy and important. So to answer that question, I'm a molecular biology PhD. I finished my PhD in 2020. Yes, I got my PhD in March last year. I've transitioned now to working as a data scientist, so I'm more involved in the analysis and modeling side of things these days. I'm also an educator, so I teach people basically about science, the scientific method, and how to code. I'm also a concerned citizen, which is why I'm using the knowledge that I've accumulated over the last 9 years to help inform people about vaccines. And most importantly, I'm going to tell you if I don't have the answer. I won't make something up. I will tell you I don't know something if you ask me a question that I can't answer. Something I'm not is a public health expert, so I can get into the specifics of the sort of molecular biology of viruses and the immune system and vaccines, but I'm not an expert in actual distribution or production of vaccines. Cool. So to give you a tour, sorry, I'm going to admit people as they pop in since I'm the host, to give you a little tour of your immune system. Cool. So to begin with, there are two types of immunity, innate immunity and adaptive immunity. So innate immunity responds quickly to a variety of invaders. So some of the cells of the innate immune system seek and destroy these invaders, and some will act as an alarm system to recruit more fighters to an area of infection. So this is kind of like a blunt force, a brute force, blunt kind of weapon against anything that comes into your body. So for example, here we have a white blood cell encountering an invader, in this case a bacteria. So our white blood cell here is the sheriff on the beat, patrolling, and it encounters this little bacteria. The white blood cell recognizes the invader immediately and engulfs it. Before moving on with its life to find more invaders to destroy. So basically if it recognizes something and it recognizes that it's not one of your own cells or a little bit of nutrients flying around your body, it'll destroy that organism or molecule. But sometimes your immune system encounters something that it doesn't recognize. In this case, SARS-CoV-2, the virus that causes COVID-19. Seems legit. Next. Until the invader is literally breaking into your cells. So here's Miss Coco looking for a host and an innocent cell just minding its own business and getting infected by COVID. Hijacking all the resources. So here we have the virus entering the cell, hijacking the cellular machinery to produce more of itself and exporting the newly produced virus. So basically it's breaking into your house, using your microwave and your stove, using all your resources and producing more of itself. Cool. And then sometimes it actually ruptures these cells when releasing the virus. And actually it's the cellular rupture and the immune system encountering cellular debris that alerts the immune system that something has gone wrong. So the first line of response failed in getting rid of the coronavirus in your body. So this is where we have adaptive immunity entering the chat. So adaptive immunity has cells that are highly specific to each particular pathogen that the body encounters. It's also able to distinguish friends from foes, and it stores a memory of specific pathogens. So where our innate immunity is this kind of blunt instrument, this adaptive immunity is a much more refined, bespoke form of immunity. And unfortunately, it also takes a little bit longer to get going than the innate immune response. So while the innate response was sleeping on the ongoing invasion, these B cells of the adaptive immunity are surveying your bodily fluids with their nets cast for any potential nasties that they might encounter. And these nets, metaphorically, are antibodies that exist on the surface of the cells that the cell uses to decide whether it encounters a friend or a foe. So if something binds to that antibody on the surface of the cell and it recognizes it as something that shouldn't be there, it will trigger an immune response. So these antibodies kind of work like a lock and key, and they live on the surface of these cells and they have different shapes. So some B cells will recognize the invader and others won't, depending on the shape of the antibody and the shape of the invader. So it's like kind of like little locks waiting for the right shaped key to come along. So here's a specific B cell, here are specific B cells antibodies able to bind to the invader and trigger an immune response. So here we have the coronavirus spike protein is recognized by the antibody on the surface of the B cell. And it unlocks that immune response. It kind of acts as a little key. So the B cell with the antibody that fits freaks the F out. And it clones itself. It makes many, many, many copies. And all of these copies of the cell have the same antibody on the surface of the cell.
Astrid?
Sure.
We have a request from chat that you go a tiny bit slower.
Oh, sorry. Sorry. Should I back up a little? Okay, I'll back up to here.
Yes.
Is that good? Cool. So to recap what I've said so far, so we have these cells of the adaptive immune system that have these antibodies on the surface of the cell. And basically, once it recognizes that something shouldn't be there, it will replicate itself so that there are many, many copies of those cells that have this kind of the specific lock. And so once it replicates itself many, many times, it can actually go and trigger the rest of the immune response. So this lock and key mechanism is very important for when we get into the actual vaccine information a little bit later on. Cool, so here we have our coronavirus, and it's able to bind to our antibody that's on the surface of the cell. So our cell is now freaking out and replicating itself. So this is the beginning of the immune response. So before, with our innate immunity, we just have these cells patrolling our bodies at all times, and they'll deal with anything that comes their way. Whereas with the adaptive immune response, it kind of figures out what is the best weapon to use against the virus, and then it makes many, 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 many copies of that specific weapon to use against the virus. So some of the cells will become fighters that'll actually go and destroy the virus itself. And some of them will become these memory cells. So these memory cells will remember what the shape of the weapon looks like, and they'll store that in your body so that next time your body encounters the same virus, it will have its weapon ready to go for that virus. So the B cells that are part of this adaptive immunity will also call in their friends called the killer T cells to come and clean up the mess. So our little B cells will signal to the T cells that, hey, there's a lot of debris here within the body that we need to clean up. So these T cells will come in and do the job of cleaning up all of that debris. So this process of, locking onto the protein on the spike, the spike protein on the outside of the coronavirus, this triggering of the immune response. So, getting those B cells to replicate, and then actually signaling to the killer cells to clean up any debris. That takes a long time. And during this time, the virus is having a party in your cells until eventually the immune response is activated. So this is why you'll only start to get that immune response a little bit later, is because it takes a long time for all of the signaling and production of weapons to happen in your body. So these memory B cells make sure that next time you're exposed to the same pathogen, they can quickly activate an immune response. So if we look at this graph over here, you might be initially exposed to the pathogen here on day 1, and it takes maybe 14 days for your body to produce these little weapons on the outside of the cells, so the antibodies. So that's kind of the level that's required for your body to mount an effective immune response. And that takes a very long time. But it's really great that your memory cells go and store those weapons, because next time you get exposed to the pathogen, so here we have a secondary exposure, you can see that it ramps up production of those antibodies really, really quickly. So within 2 days, you're able to have the same response as it took you last time 2 weeks to get from exposure to the virus. So yeah, thanks to these memory cells who store the shape of the antibody for later use. So how do vaccines work? So back to our friend the B cell. Many years ago, scientists figured out that you don't actually need to wait to get sick to develop immunity to diseases. So you can go that route. So people who will get exposed to chickenpox in their childhood probably won't get chickenpox later in life, because they develop this immunity. The immunity being represented by the shape of these antibodies on the outside of their immune cells. But if you inject an activated virus into healthy people, these B cells will be stimulated exactly the same way as if there was an infection. And so they can still mount an effective defense, still activate those little memory cells that go and store the shape of the weapon. So that's basically the premise of how all vaccines work, is they basically inject you with inactivated virus or inactivated bacteria, or a little piece of the virus or bacteria, and that triggers your immune response and stores the information on how to attack that specific invader next time around. Cool. So a quick word on the SARS-CoV-2 virus structure. So this is the actual molecular structure of how the virus looks. So there are lots of little components, but the ones that are important for our vaccine discussion are, there's this little protein coat that keeps everything together. There are these spike proteins, which are used to invade cells. So these little spike proteins actually go and kind of latch onto a cell, kind of how you would imagine, you know, when you're walking in the forest and you get blackjacks attaching to you, you can think of it as kind of analogous to that. These little spike proteins go and attach to cells, and this genetic code that has the instructions for how to make more virus is injected into your cells. So basically, this is the recipe book. Remember when I gave the analogy earlier of the virus coming into your body, using your microwave, using your stove, using all the ingredients in your fridge? This genetic code is basically the recipe book of how to make the virus. So that's kind of the basic structure of this COVID virus. So until very recently, just a piece of the virus outer layer, so the spike protein in the case of COVID-19, would do for generating a vaccine. So you would just basically take your viral particle, break it apart, and basically filter out just these spike proteins, and you would inject that into the human. Our B cells would recognize them, freak out, make memory cells, and make fighter cells. And so that adaptive immunity is triggered without viral infection occurring. And in more sophisticated cases, they don't actually even have to create a lot of virus. They don't have to make these viruses. They can just produce the protein subunits themselves. They don't have to actually go and have a high-risk laboratory environment where they're growing virus. They can just produce the little the actual spike protein. So this is kind of how vaccines have worked throughout the 20th century, and indeed the AstraZeneca vaccine actually still works like this, and it's really come a long way since things like the polio vaccine, in that the technology behind producing these proteins is really, really advanced. So you can get quite broad immunity, even though it's a little bit more of a blunter instrument. But scientists have also developed these mRNA vaccines, which use the genetic code that's contained within the virus rather than the spike on the outside. So they take the recipe instead of taking the cake at the end, and they isolate the little piece of genetic code that encodes for the spike protein, and they use a version of this little piece of genetic code to inject into you for your, so basically they inject this little piece of genetic code into your body, and your body can then go and take that little piece of code and produce the spike protein. And if that sounds really weird, like they are genetically modifying you, that's not at all what's happening. That little piece of genetic code doesn't hang around in your body for very long. It won't integrate into your genome itself. It'll just be in your bloodstream, and it'll produce the spike protein, and it'll be gobbled up very quickly. So it'll produce the subunit, the spike protein, and then be gobbled up quickly by various enzymes in your body. So it doesn't actually alter your genetic code at all, and it's destroyed after a while. So why do we want to do this route rather than sticking to the old faithful of just injecting people with the actual spike protein itself, if that works perfectly well? So there are a few pros to using these mRNA vaccines. It's quicker to produce them. We can do so synthetically without traditional methods, such as vaccine production in eggs, which has a longer turnaround time. So historically, people would actually get many chicken eggs, and they would produce their vaccine in those. And that has a longer, months, kind of 2 years turnaround time, which is when you're just generating a tiny little piece of mRNA, so the genetic code, that takes a lot quicker. They also elicit a broader immune response, so both the B cells and the killer T cells are stimulated, whereas with the protein subunit vaccine, that's only the B cells that are stimulated. Another big pro is that this technology has been developed on other viruses for almost 30 years, and this is this is the first large-scale global collaborative effort to deploy these vaccines. And on average, they're reported at about 90% effective at preventing COVID-19. And I have a few sources linked here. I'll share the slides afterwards if people are interested in getting a little bit more detail on each of those points. So there are some cons of mRNA vaccines. So, side effects are observed in some patients. Most are classic immune response related, so fever, chills, pain, the kind of response that you would get from a traditional vaccine as well. And some patients experience allergic reactions to some ingredients. So I think in the 21st century, we're realizing that really medicine is not tailored to everybody the same way, and some people will have allergic reactions to some ingredients. I think a way to counter this is to just make sure that where you're getting your vaccine, there's somebody on standby who could help you if you needed some medical help. Another con is that storage conditions vary between formulations. So some require a minus 20 degrees Celsius storage. So, if we're getting vaccine out into rural areas or places that don't have great infrastructure, a minus 20 freezer is not always a great option. It's not really an option at all. And the reason why they require this minus 20 storage is because that genetic code, that RNA molecule itself, is very kind of unstable. And that's a good thing, because you don't want that genetic code to be hanging around in your body for a long time. You want it to be quickly used and quickly gotten rid of. just have it there long enough for you to actually develop your immunity. Okay, and then another thing is that there's lack of large-scale public education on how these vaccines work, and that is a problem. But this is a problem that scientists need to get a bit more savvy with actually communicating their work a bit more. You know, they just say, "Oh, it's safe," but they don't tell you why it's safe or how it's safe, and that's an issue that needs to be addressed. And then I included a few links here, so more information on the Moderna vaccine, including the demographic breakdown of the study participants, the Pfizer-BioNTech vaccine as well. So the Moderna and the Pfizer vaccine are both this mRNA vaccine. And CDC approval for the AstraZeneca vaccine is pending, but there are some interim trial results here that I also linked. So the reason that the AstraZeneca vaccine hasn't been approved yet, that protein vaccine, is just because it takes a little bit longer to develop. And so they aren't quite at the same phase of the vaccine development as the two RNA vaccines. Cool, so I just wanted to maybe, if we have time, just address a few concerns. Like a lot of people have been asking, you know, I'm mostly healthy, why should I be vaccinated? So,
Astrid, could I ask if you could go through these slides quite quickly, just to quickly wrap up? Thank you.
Cool. So yeah, so getting COVID still really sucks, even if your chances of hospitalization, you know, long haul COVID is still being studied. So, you know, you don't necessarily want to get that particular version of COVID. And herd immunity, this is the most important thing, is that herd immunity is really essential for the most vulnerable people in our society, people who can't be immunized due to other medical conditions, be that immunosuppression or overly active immune systems. So having that herd immunity is really important for those people. One last thing I want to talk about, I'm sure other people will have more information on this, but why were these vaccines developed so quickly? This is like a big point of skepticism that people have, which is healthy. And I just wanted to talk about that a little bit, is that a lot of money has been poured into this specific vaccine because it's affecting everybody's lives. It's not just affecting a specific portion of the population. And you know, there's been a lot of global collaborative effort on actually sharing the genetic sequences of the coronavirus. This platform has been in development for over 2 decades, and you know, a lot of the manufacturing of the vaccine has also been carried out in parallel with clinical trials, you know, with the hope that clinical trials will succeed. And you know, fortunately, them hedging those bets was beneficial. And it wasn't hard to get people enrolled in this vaccine trial, and it's usually much harder. So usually the recruitment process takes months, whereas in this case, it took days, weeks to get people to actually come and get vaccinated. Last slide. These resources that I use, like in my day-to-day life, the top one is monitoring COVID numbers in South Africa, a wonderful dashboard to do that. And the second one is the WHO guidelines of how to behave with COVID consciousness. So those are my new 10 commandments, and I highly recommend these 2 links. Thanks so much. I hope, yeah. Sorry for going a little bit fast at the beginning, but thank you so much for your time and for the opportunity to share.
Marlies, you're on mute.
Thank you. Astrid, thank you so much. That was awesome. I think you were presenting and letting people in from the waiting room. So well done on all that multitasking. That's amazing. Could I ask if you can hand the controls over to Fredy Lee so that she can project her slide? That was really useful. Thank you. I'm still thinking quite a lot about all the interesting points that you made about the RNA vaccines. Let's hear Fredy Lee. Are you sorted with your slides? Perfect, thank you. I would like to introduce Fredy Lee Boyson, who was at the Treatment Action Campaign for 10 years in various capacities, and has been a key resource person and in treatment literacy and experience, and I'm going to hand over to her, Fredy Lee. Please take it away. Thank you very much.
Okay, so good morning, colleagues and listeners, as well as viewers. So maybe just to add that I've been in the NGO sector for more than 20 years, and I still continue to work in and with communities, and I think I see myself as a kind of a community development practitioner. I also hold a Master's of Education, which I got at a UCT, and before I started at TAC from maybe the late 1990s to 2004, I was a volunteer of TAC. And then, like Marley said, between 2005 and 2015, I was a staff member of TAC. Currently, I'm working for an organization called Sonke Gender Justice, and I'm a unit manager at Sonke. As part of my presentation, I would like to acknowledge the sacrifices that many volunteers made, sacrifices that staff of TAC made, healthcare workers, many organizations like Section 27, CASATU, civil society organizations, NGOs, many efforts and working together and sacrifices was made to make sure that we as South Africans have access to treatment today. So I'm just going to touch a bit about HIV and a little bit of what was happening and why TAC was started. Then I will do a bit of an overview of the literacy program. And then I would like to make some recommendations, which I think is still relevant for today, for the current situation that we're in. I only have 15 minutes. So what I'm going to say is but a drop in the ocean, because there's so many pieces and levels of the literacy program. And I would say a person would need about 2 to 3 hours to really get into that. But I'm going to try my best to give you some insights about the literacy program. And I hope it will assist us all for the current times of uncertainty that we are in. So in terms of the background, I think we all can say that we've heard about Treatment Action Campaign and the history of HIV and AIDS in South Africa. It's very well documented. And we have heard about the state's controversial stance and the response to the epidemic. Maybe just to say, give a few examples around the government in action, the conflict between and amongst political party politicians. We know about the AIDS denialism. There was differences among scientists in terms of what tools and methodologies to use. There was a lack of political will and leadership, and then in general, there was weak policies. So if we look at the current situation, we find ourselves where we're in a country where people don't trust the government. Examples that we can make, for instance, is the COVID corruption. We're all aware of it, but have we seen anyone go to jail for that? A very recent example is the Premier of Mpumalanga. She didn't wear a mask, but if we look on social media and what the Minister of Police is doing is to arrest ordinary citizens and show police brutality because people is not wearing masks. Another thing is we've all heard about the national vaccination plan, but there's so many people that does not understand or have heard about it. So these are all things that makes people not to trust government, which is going to have an impact on the vaccinations. Because we need a situation where people understand and where people have information, because the lack of information makes that people cannot make informed decisions about their health. And then we've seen over social media for the past 3 months, the video clips that is doing the rounds, the conspiracy theories, and that is not really helping the situation. So there were similarities, that a person can say that happened back then. But I think the key thing that stands out is the fact that we have proof. and we have evidence that those vaccines work. Just like back then, when the treatment, when ARVs was about to be administered, there was enough proof and there was enough evidence that ARVs is safe. So when TEC was launched, its main purpose was to ensure access to safe and effective HIV treatment. And TEC used different strategies like community and social mobilization, education, research, the use of the media, and the South African Constitution and law. But also what we need to keep in mind that one shoe doesn't fit all. So we have to look at different things for different people and different communities because it differs. So a little bit about the background in terms of the literacy program. The treatment literacy involves health education and communication that focus on education, HIV positive and ordinary citizens about the science of HIV, health, and the benefits of treatment. This was based on the idea of the positive benefits of public health education and information. And the main function was to empower citizens and groups of people to acquire power over their health by increasing their understanding of HIV and AIDS prevention, care and treatment, and as well as the rights and responsibilities of patients and healthcare professionals respectively. TEC developed a range of simple educational resources which included posters, pamphlets, booklets, magazines, videos, and combined these with an extensive training programs. Part of those resources also included face-to-face education, information sessions, distribution of HIV and AIDS material, workshops, and that was like a package for the literacy program. So treatment literacy was not taught in a neutral or biomedical fashion, but it was information about the science of medicine and health. It was linked to political science, human rights, equality, and the positive duties of the state. So it wasn't one focus on HIV and AIDS. And again, it was packaged in a way so that people can have more information to make informed decisions. TEC used the TL program as an instrument to rally communities to demand HIV treatment. And this is also where the campaign part of the literacy program came in. Because when the practitioners or the program disseminated information to communities, people were also recruited to be part of branches, and those branches were equipped to fight for access to treatment. So in all of this, we also need to look at what campaign is relevant that a person can take forward to make sure that people understand vaccination within South Africa, as well as the plan. So the program also created a cadre of highly informed activists that openly challenged the misinformation put out not just by government officials, but by scientists, religious leaders, politicians, and traditional leaders during the years of denialism. So I think it's still important for us to develop that cadre that can challenge anyone that is causing confusion when it comes to the administration of the vaccine. So the model was adopted from the USA, where AIDS activists led by people with HIV had pioneered the idea of treatment literacy among people with HIV. What is different though is that TEC became the first AIDS activist organization to pioneer the concept of practice of HIV treatment literacy in the developing countries. So about the literacy program, about the literacy program, it was one of TEC's primary community outreach programs. This program was conceptualized and implemented to coincide with the introduction of ARVs into the South Africa's public health care system. Its aim was to assist with the dissemination of information on ARVs, their side effects, the benefits, and the need for strict adherence, as well as other important information about health and patient rights. And for me, I think this bullet point is still very relevant for what we are going through today. And then the literacy program also addressed the lack among the South African general public of scientific and evidence-based knowledge on TB, HIV, and AIDS prevention. And I think it's safe to say that currently people do not know enough. And it's important, like Estrid is doing, to provide scientific evidence-based knowledge so that people can be able to make informed decisions about their health. In addition, the program provided public education and training and monitored levels of HIV and TB services at the facilities in which TAC operated, and this was predominantly in underprivileged areas and townships. So this is still relevant for today. We can also monitor service, especially in our areas, and we do not have to rewrite things. We can look at what is existing right now in terms of community platforms that we can use to monitor the facilities and where the vaccines will be administered. The TL program also had a structure. So we would have peer educators, you would have your treatment literacy practitioners, you would have your trainers, you would have your education coordinators. So there was a structure and there was a HR strategy. And the program also had a curriculum, which is that was quite formalized. But it doesn't mean there wasn't informal things that was in between informal learning. As I already mentioned, the building of branches to organize for treatment, that was strategic, and that was the campaign part of the program. TL, the treatment literacy, was in the center of everything that the organization did at the time. Treatment literacy was in the center of the different programs that TAC had, and I think TAC had 3 programs at the time. Treatment literacy was in the center of the campaigns, in the center of the branches, and of all the work that TAC did. And every individual that worked for the organization was treatment literate, and I think that is very important. So again, what stands out for me from this information is that the importance of public education and the importance of having to monitor what governments say they do, that we really monitor that it is really what they are going to be doing and what they are doing. So a few recommendations from my side. It's important to provide up-to-date, simplified health information based on best practices, evidence-based science, which must be used to challenge the myths, the fears, and the misconceptions that foster stigma and add to the spread. This information must equip individuals and communities with the information needed to make informed decisions about their health. And I think it's still important to train a cadre of people to disseminate simplified health information and challenge people that cause confusion. We also need to look at providing information on the challenges and the successes within the healthcare facilities and communities, specifically around the execution of the National Plan for Vaccination and the information and informing the advocacy work at the community, district, provincial, and national level. And what I mean by this is when the vaccines will be administered at the different levels, we will have to look at the success stories, what is coming out of the communities, so that others can learn from that. But also we have to look at the challenges that is coming with the vaccinations at all levels, so that this can inform our advocacy work. And then under the implementation plan, we need to monitor facilities that will monitor that will administer the vaccines, and we can use existing community platforms. Then I think in conclusion, at the time before ARVs became available, thousands of people were dying. And currently we're in a similar situation where we have thousands of people that is dying of COVID. And again, we find ourselves where all the efforts from different levels need to be put together. And for civil society and ordinary citizens, we have a role to play to make sure that we save lives. Thank you.
Fredy Lee, thank you so much. It feels really mean to both you and Astrid to give you so little time, but you both did so great. I'm aware that we had lots of content to get through, and that the questions have been coming in the chat box. Thank you very much for Astrid and others who've been giving some input there. We have about 5 or 7 minutes for questions, and I'm going to assure everyone that if you don't get your chance to ask a question now, that we are going to endeavor to have your question answered afterwards. So I'm going to open it up for verbal questions, and if you see that your question is not going to be answered, please put it in the chat box, and we are going to liaise with Fredy Lee and with Astrid to find ways that we could answer the questions, perhaps through some of the different togethers, their social media channels. Can I see any hands of someone who wants to ask a verbal question? Okay. Julie, could I ask you if you could choose a question from the chat box if you would like to ask that?
Hi, we have a question from Steph, or we have, I think, yes, it's for Fredy Lee. The rapid worldwide education response to the COVID-19 situation should be used to remind the same populations to also protect themselves from HIV infection. Oh, I think this is more of a comment, sorry. So in the same way they encouraged to prevent infection with SARS, COVID-2 with the face mask, so should they also be encouraged to use condoms to prevent HIV infection. That's a great comment. Thank you, Steph. So I have a question for Fredy Lee. Do you think that elections will affect the misinformation about the vaccine this year?
Thanks, Julie. Great question. Fred, what are your thoughts on the election and information?
Yeah.
Short.
I think, okay. I think the important thing is to make sure that we have a group of people that have a strategy going into the elections, so that our politicians and our government does not use the elections to score political points. Because I think in the era of HIV and AIDS, the same thing happened. So I don't have any specific suggestion right now, but I think it's important to follow the process of the elections and to make sure that if they cause or they give misinformation or they cause confusion, that we have civil society that speaks out against that, so that they can understand that they're not going to get away with it. Even if it means that we need to go as far as the Human Rights Commission and use all the relevant channels and platforms to demystify what they are busy with. So I think we need to be very vocal, like we normally are during election time. So we should have the same consistency and urgency to address those issues when they come up during the elections.
Thank you very much, Fred. That's awesome. Sorry, Julie. I see there's a hand from someone called MS Fuser. MS Fusers, would you like to unmute yourself and just introduce yourself and let us know who this question is directed to?
Morning, everyone. It's Pumeza here from MSF in Khayelitsha. So the question I'm not sure where this question is going to, but it's a question that most people in Khayelitsha are wondering. So will this vaccine be a once dose off, or will they have to be going back again for a second dose or a third dose? What's going to happen? And again, will this be a separate program that the government is going to be having, or is it going to be integrated in the services that the facilities are having, so that a person can maybe, I don't know, it's going to be put on the folder? Will you have a certificate of it? If you want to move to another country, will you need to be producing something that shows that you were vaccinated?
Thank you, Pumeza. I'm going to ask Astrid to answer that question. And I see Erica's hand is up as well. So Erica, if you want to add your question, and then I'm going to hand over to Astrid. Thanks so much, Pumeza. Erica.
Hi. I just wanted to see if Astrid could also clear for me my understanding that none of the vaccines will actually stop transmission, and you will still get sick, but not so badly.
Cool. Thanks, Erica. Great question. Astrid, are you happy if we take Monde as well?
Sure.
Cool. Monday, could you unmute yourself and tell us about your question?
Hi, can you hear me?
Hi, Monday, we can. Thank you.
All right, thank you. Thank you guys for the presentations. Just a few quick questions. One, Dr. Astrid, do we know when the AstraZeneca vaccine will be made available? And the other one is, I haven't seen most of the vaccine campaign initiatives, so I'm not really sure what is going on that front. But I recently saw a presentation by government, and I was quite worried that if you start looking at adverse events following vaccination, it's placed almost like at the end, you know. And for me, I'm a bit concerned because with the kind of misinformation going on, we might actually, be headed for challenges on that front. So I don't know whether we would be willing to look at some sort of like a social compact in the different.
A social contract.
Compact.
Social compact.
Yeah. With the various provinces, I think as Gauteng together, the working group, there might be an interest in this. Can we look at that? Because, like I said, I'm worried about the pre-phase. The preparatory phase of the rolling out of the vaccine, instead of looking at the tail end. Of this rollout. I think, maybe the others I'll ask later on when there's an opportunity to ask. Thanks.
Thank you, Monday. Thanks very much. I'm going to suggest that these are our last questions for verbal answers, and I'm going to ask everyone on the call if you have any other questions to put them in the chat box. We will have some of them. We'll have the chat as part of the video. Thank you, Judy, and your names will be blanked out. And if we don't get to all of the questions, we will post them on the messages on social media afterwards. Astrid, could I ask you if you could field some of these questions? I started writing them down, but I don't think I got all of them. So
I think I have them. Okay, so the first question was how many doses for the vaccine? As far as I know, most of them will have 2 doses. I think about 28 days apart. The last I read, that was kind of the strategy. I think, different vaccines will have different dosing regimens, but it should be a few weeks apart. And the reason for that is just to, really make sure that you're getting that good memory cell, storage, put it that way. Okay, and then the question was about certificates. I'm assuming that there will be some kind of certificate situation because, to travel to specific countries, you need to already show that you're negative for COVID. I don't know, this is not my area of expertise, but I'm assuming that will probably be a thing at some point. Depending, on the country or, not my field, but I suspect that will be a thing. Then there was a question about transmission. So I am not sure. I'm not sure if that's. I don't actually know the answer to that. I'm not sure if that's a misinformation situation where people are saying that you'll still be able to transmit COVID even if you've been vaccinated. But I will do some research and I'll include that answer in the answer pack that we're going to release after this call. I'm assuming we're going to have like a Q&A answer pack. So I will go and do some research around that. Sorry, the final question from the gentleman with the very lovely profile picture of his family. Monday. Sorry, could I have maybe that's more a question for Fredy Lee.
Okay.
I'm not sure.
Thank you. Thank you, Astrid. I see that Fredy Lee's got a hand up. So I'm going to Astrid, thank you so much. That was great. Fredy Lee, would you like to answer some of those questions and include your concluding remarks?
I'm not sure what the last question was that I have to tackle, but maybe because I wanted to attempt to look at what Pumeza was saying.
Yes, go for it, please.
And I think, again, the importance of looking at the lessons from the treatment literacy program is that it's important for ordinary South African citizens to understand the national rollout plan for vaccines. And currently we know that there's not enough time and resources that is being spent on public education for ordinary citizens. And it's on us to understand what is in that plan. And I think we have to look at calling government out to come to communities, to come and answer questions so that people can understand and be comfortable and confident in this process. Because at the moment, I see they're going to certain groups that they want to vaccinate, but they're not looking at the population as a whole. And the introduction of something is very important, but already they're looking at the administering of the vaccine. So we need to look at calling in bezos. We need to look at setting up meetings with government officials, and they have to come and explain to the communities, because at the end of the day, they will need us, and we're also going to need them so that we can work together for this thing to work. So that is my part.
Thank you. That's a very powerful conclusion to this morning's session. I want to thank Astrid. I want to thank Fredy Lee. I want to thank Julie and Toko for the assistance with the hosting. And I'm aware that other people have to go to meetings at 9 o'clock. So I'm going to ask people to please quickly put on your video if you want to, and to just give a little wave to end off the session and to say thank you very much to our speakers. Thank you so much, everyone. Have a great day, and please have a look at social media for this video that will be posted there together with some resources. Thank you, everyone.
Guys.
Have a good day. Bye.
Thanks. Bye.
Thanks, everybody. It was really wonderful to spend some time with you, and hope everyone has a great week.
Thanks, guys.
Bye, everyone.
Bye-bye.
Thank you. Bye.